Hi there, my valued and treasured viewers and listeners, and welcome back to this channel. My name is Dr. Nath Arwa, and I'm the founder of Progressive Pharmacotherapy Consultants, the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. We seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, sit back and spare me part of your precious time to share some useful tips with you. So, welcome to part 1 of our pharmacotherapy MCQs. Now, the first question reads, which of the following antiepileptic medications put or puts the patients with HLA B star 1502 allele at an increased risk of SJS, Stevens-Johnson syndrome? Is it carbamazepine? Is it gabapentin? Is it valproic acid, or is it Keppra, levetiracetam? Now I'll give you 10 seconds to make a rational decision before I display the correct answer. So dear listener and viewer, if you chose carbamazepine, you are right. And I'll try and clarify why I strongly feel that's the best alternative. Now, there is a strong relationship between HLA B star 1502 and carbamazepine induced SJS and 10, especially in the Han Chinese population, in the Thai, and also in the Malaysian populations. Now, this same relationship can also be found in other anticonvulsants such as phenytoin and lamotrigine. So, for patients that have this allergy, I would advise you to be cautious when transferring them from carbamazepine to either of these two, phenytoin or lamotrigine. So in our second question, JMK is a 59-year-old female patient who is admitted to the E&E with the diagnosis of diabetic ketoacidosis, DKA. Due to her poor respiratory status, you end up intubating her, and some of her pertinent lab results include sodium levels of 128 millimoles per liter, very high potassium levels of 7.6, chloride of 98, and among other things, her serum creatinine is high at 3.4. Her blood glucose is extremely high at 1813. The pH is 6.84. So from those results, what is her anion gap? I'll give you a few seconds, 10 seconds to be precise, to calculate her anion gap. So I'll go ahead and display the correct answer, and I know you are good mathematicians, so I'll give you another 10 seconds to read through the way I've calculated and gotten to the correct answer, which in my opinion is 24. So we can now proceed to the next slide about the same patient. Now, she is a 59-year-old, as we were told earlier. The lab results remain the same. Now, the next question reads, what is the appropriate choice of IV fluid that you need to initiate in her case at this particular time, based on the above results? So I'll give you another 10 seconds to make a rational pharmacotherapeutic decision before displaying the answer that I feel is correct in my opinion. So let's move to now. In my opinion, answer D is correct. I would infuse 150 milliequivalents of sodium bicarbonate dissolved in sterile water. Now, this patient's corrected sodium is high. Her glucose is also high. So such a patient shouldn't receive normal saline or any IV fluid containing dextrose 5% at the moment. Now her pH, which is 6.84, is less than 6.9, so she must receive sodium bicarbonate according to many guidelines out there, which should be infused. Now, when I look at her results, she should not receive concurrently sodium bicarbonate diluted in normal saline, because this would make that solution hypertonic. Yeah, so that makes solution D superior to solution C. Yeah, you would avert a case of infusing an unnecessarily hypertonic solution. So I would go with solution D. Let's move to the next question. So in this next question, with the same results, I would like to know from you, what is the treatment of choice for her hyperkalemia at this time? Remember, it stands at 7.6. The ideal should be anything around 3.5 to 5 or 5.5. Is it sodium polystyrene 60 grams administered rectally once as a start dose, or is it 10 milligrams of albuterol administered via nebulization, or should you continue insulin drip with no other treatment, or should you administer sodium polystyrene rectally at a dose of 60 grams and nebulize 10 milligrams of albuterol? I'll give you 10 seconds to make a decision. I'll move to the next slide, and in my opinion, the correct answer is C. I would continue infusing insulin and add no other treatment at this stage. Now, her current potassium level stands at 7.6, and she is currently receiving insulin, which is the standard treatment for her hyperkalemia. Now, because her pH is still below 6.9, she should receive sodium bicarb. Now, this will eventually push the potassium intracellularly, and eventually the pH will gradually rise, and it will bring down her potassium alongside the insulin drip. So, a question for the statisticians: in a publication observed mean weight of 200 patients was reported as 69.4 plus minus 9.3 kilograms. Now, if 9.3 kilograms is the standard error of mean, I would like you to calculate the standard deviation and the variance in this particular question. So I'll give you 10 seconds to make a rational decision before I display the answer that I feel is correct in my opinion. So in my opinion, from my little arithmetic, the correct answer is A, and I'll pause and give you a chance to see how we got at the two answers. So let's move. Now the same patient deteriorated and she was transferred to your ICU, and propofol was initiated alongside norepinephrine drip, and at this time you began infusing 5% dextrose plus 150 milliequivalents of sodium bicarbonate at a rate of 150 mLs per hour. Apart from that, you also began potassium, magnesium, and phosphorus replacement according to your hospital protocol. Now, a few hours later, her lab results were repeated, and the pertinent labs were sodium 146, the potassium fell, it was driven into the cells, and it currently reads 2.5, the chloride is 103, phosphorus 1.2, the triglycerides are 741 milligrams per deciliter, the blood glucose has fallen slightly to 735, pH has risen slightly to 7.265. She doesn't seem to be saturating well, and the serum creatinine is slightly improved to 1.2 milligrams per deciliter. At the moment, what should be her appropriate drug of choice for sedation? I'll give you 10 seconds to pick from one of those four. Is it propofol? Is it midazolam, fentanyl, or cisatrachium bacillate? Now, in my opinion, the correct answer is B, midazolam. Now, I opt for this one because this patient, according to the labs, has high lipid or triglyceride levels. So, propofol should be avoided for sedation in this case, since it has been shown to increase triglycerides. Midazolam is a better option. Now, fentanyl is never or rarely used in monotherapy, so I wouldn't opt for fentanyl. And our last option is a paralytic, so that becomes the wrong choice. So my correct answer in this case would be option B, midazolam. So still on the same patient, the labs haven't changed much. My question to you is, what should be her drug of choice for the treatment of the chronic high triglycerides? Is it fish oil? Is it fenofibrate? Is it atorvastatin? Or do we need to leave her as is without intervention until high triglycerides get to above 1,000 milligrams per deciliter? I'll give you 10 seconds to make a rational therapeutic choice. So in this case, I would settle for fenofibrate. Now, for triglyceride levels above 500 milligrams per deciliter, it is reasonable to start intervention in some kind of way, to start pharmacological therapy in addition to lifestyle therapy. Now, fibrates are the most effective when it comes to decreasing triglyceride levels. Fish oil and atorvastatin are not the best drugs for lowering triglyceride levels in serum. Statins are, however, the first-line agents when we need to reduce LDL. So that makes B, fenofibrate, the correct answer. So you do a good job. You transfer JMK to the ICU on propofol, on norepi, on dextrose 5, and you continue replacing the potassium, magnesium, and phosphorus according to your replacement protocol in your hospital, and a few hours later the labs are repeated, and the pertinent labs are the sodium is still 146, potassium hasn't changed, nothing much has changed as such. So is which one of the following approaches is the appropriate course of action in her case in regards to her low phosphate levels? Is it give her 30 millimoles of potassium phosphate for phosphate level 1.2 milligrams per deciliter, or give 30 millimoles of sodium phosphate for phosphate level 1.2, or it is not recommended to replace phosphate unless the concentrations fall below 1, or is it replacing phosphate can cause hypermagnesemia and hyperkalemia? I'll give you 10 seconds to make a rational therapeutic decision. So in my opinion, C is the correct answer. At the moment, it is not recommended to replace the phosphate. Most guidelines say unless it falls below 1 milligram per deciliter. Remember, her sodium remains 146, her potassium is still 2.5, her pH has risen to 7.265, and her blood glucose is falling steadily to 735. I would opt to leave the situation as is. Now her phosphate is still 1.2 at the moment, so it is not recommended to replace the same until it falls below 1. Now when phosphate is replaced for levels greater than 1, you face a very high risk of ending up with hypomagnesemia and hypocalcemia, and not hyper as we have in the case D. Yeah, the phosphate would bind them, lowering serum levels. So answer D would be inappropriate. So in the next question, I would like to know from you, what should the IV fluid be changed to? Would you switch to half strength normal saline? Would you switch to normal saline? Would you infuse dextrose in 5% in normal saline? Or would you stick to sodium bicarbonate in sterile water? I'll give you 10 seconds to make a rational pharmacotherapeutic decision. So in my opinion, the correct answer would be A. I would switch to half strength normal saline. Now for sodium levels above 145 millimoles per liter, the IV fluid should be half strength normal saline. Now for levels below 145, you should be on normal saline. Now, the corrected sodium for this particular patient indicates that it still remains above the 145 level. Bicarbonate drip should be continued once your pH exceeds 6.9. Now in our case, we're already at 7.265 if I remember well. Our potassium remains 2.5, and blood glucose, if I remember well, is at 735. So it's time to discontinue the sodium bicarbonate to avoid complications. Dextrose 5 should not be infused at this time because blood glucose levels exceed 200 milligrams per deciliter. You will find that in most guidelines. So let's to the next question, where I would like to know from you, when should her insulin drip be discontinued and switched to subcutaneous insulin? Is it once her blood glucose gets to 200 and her serum bicarb gets to above 25? Is it once her blood glucose gets to below 200 and her venous pH gets to above 7.4? Or is it when her blood glucose falls below 150 and her serum bicarb exceeds 25? Or is it D, when her blood glucose falls below 200 and the anion gap gets to equal to or less than 12? I'll give you 10 seconds to make a decision. So D is the correct option. I would switch it off once the blood glucose falls below 200 milligrams per deciliter and the anion gap gets to equal to or below 12. Now, insulin drips can safely be discontinued once our blood glucose levels fall below 200 and the anion gap is equal to or less than 12, or when the blood glucose falls below 200 and the venous pH exceeds 7.3, not 7.4, and the serum bicarb should be 15 or more, not 12 like in the case, 25 like in the case of C. So that makes option D the correct one. Let's move to the next question. So our next question reads, which one of the following is or are nominal data? Something for the statisticians. So is it sex or gender? Is it race? Is it blood group? Or is it all of the three above? I'll give you 10 seconds to choose one option from the four. So in my opinion, D is the correct answer. Nominal data is usually considered unordered data, or they belong to unordered categories. Gender can either be male or female, which makes it nominal data. Race can have multiple answers. There are no in-betweens. It can either be Caucasian, African American, Asian, and so on and so forth. Blood groups are also specifically either as O, A, B, or AB, which makes it nominal data. Now, nominal data would have categories that are in some, so ordinal data would have categories that are in some form of order. So let's move to the next question. That makes answer D correct. All the three, A, B, C, are forms of nominal data. Now, in the next case, our patient NWO is a 72-year-old female patient who is admitted to your ICU with pneumonia, atrial fibrillation, congestive heart failure with preserved left ventricular function, and her weight is 76 at the moment. Now, this lady has a history of lung cancer for which she's being treated with cyberknife and chemotherapy as an outpatient. She has a history of hypertension, hyperlipidemia, hypothyroidism, and chronic obstructive pulmonary disease, COPD. Now, on admission, her WBC is 1K. The bands are 32%, the segs are 42%. Please note those values. She was initiated on the following antibiotics: vancomycin infused over an hour, levofloxacin, and aztreonam for her hospital-acquired pneumonia. She is also on your hospital's electrolyte replacement protocol. Now, this lady is allergic to penicillins and cephalosporins, and when you probe further, the next of kin tells you she had a rash the last time she received IV cephalosporins and when she took oral penicillins. For her AFib, she has been given amiodarone 400 milligrams orally twice a day. Now, we know that amiodarone has challenges with the hypo or hyperthyroidism, so keep that at the back of your mind. It messes up the thyroid gland. She's also on diltiazem, which is being infused at 10 milligrams per hour. She also received a few doses of furosemide for her congestive heart failure. So, what is her absolute neutrophil count according to the details you've been given in this answer? I'll give you 10 seconds to quickly compute that, then I'll display what, in my opinion, is the correct answer shortly. So is the answer 740? Is it 500? Is it 420? Or is it 320? Arithmetic, 740, option A, is the correct answer. And I'll give you 6 seconds to look at how I got to that answer. Now, in case you need more time, you can pause the video and have a look at it. The next question applies to the same patient. Everything remains as is. Now, the physician would like to treat her low absolute normal count, neutrophil counts, ANC. Which one of the following would be the treatment of choice with dose when you pay attention to her ANC, which is low in this case? Would it be filgrastim 380 micrograms subcutaneously daily? Would it be the same drug 480 micrograms subcutaneously daily? Would it be erythropoietin 10,000 units subcutaneously daily? Or would you give her fresh frozen plasma at a rate of 15 ml per kilo? I'll give you 10 seconds to choose from the 4 options. So in my opinion, A would be the correct answer. Remember, our patient weighs 76 kilos, and the correct drug of choice would be filgrastim, administered at a rate of 5 micrograms per kilogram per day subcutaneously. Now, considering that this patient has received pharmacotherapy and we are unable to determine exactly when, this dose is consistent with the indication of primary prophylaxis in a patient with non-myeloid malignancies. Now, erythropoietin would be the wrong choice because it's indicated in the treatment of anemia due to various causes. And fresh frozen plasma is given in certain bleeding disorders to replace the factors. So when you quickly compute 76 times 5 mics per kilo, it gives you 380. So A would be our best option in this particular case. Now we are still on the same patient, so my question to you this time round is, what significant drug-drug interactions do you identify in this patient's case? Is it furosemide and amiodarone? Is it vancomycin and amiodarone? Is it aztreonam and amiodarone, or is it levofloxacin and amiodarone? I'll give you 10 seconds to make a rational decision. So in my opinion, the major drug-drug interaction I see that would grossly affect her treatment is D, between levofloxacin and amiodarone. There is a drug interaction between the two which increases the risk of QT segment prolongation. Now, levofloxacin is associated with QT segment prolongation and at times can cause dorsal de pointe. Amiodarone also has a risk of QT prolongation and may also cause torsade. This drug-drug interaction is possible even weeks after you've stopped amiodarone because of its long half-life. Yeah, so you need to be very cautious when using the two together. There is also a drug interaction between furosemide and amiodarone. So caution must be taken because loop diuretics can lower both potassium and magnesium levels. This can endanger the patient's life, in my opinion. So I would be careful, but the option D poses a bigger danger than furosemide and amiodarone. And apart from that, the patient appears to be on an electric replacement protocol, so I would not worry so much about hypokalemia or hypomagnesemia at this stage. In the next question, SAR has thyroid issues. The TSH is 0.041 mega units per liter. Now the normal range varies. There are forms of literature that quote 0.4 to 4, but in this case they quote 0.36 to 3.74. Now SAR has been taking 125 micrograms of levothyroxine orally once a day in the morning after her breakfast for more than 12 months. What, in your opinion, should be the most appropriate drug regimen modification to correct her levels? Remember, it falls outside the recommended range. Is it increase the dose of levothyroxine to 150 mics per day? Would you decrease the dose to 100 micrograms orally per day? Would you increase the dose to levothyroxine 150 mics IV daily? Or would you decrease the levothyroxine dose to 100 mics IV daily? I'll give you 10 seconds to make a decision. So in my opinion, B is the correct answer. I would decrease the levothyroxine dose to 10 micrograms orally a day. Now, the TSH level is below the therapeutic range, which is 0.358 to 3.74 million units or mega units per liter. So her TSH is TSH as such is generally inversely related to the thyroid hormone levels. And I would like to comment that by equivalent of oral to IV levothyroxine is 2:1 ratio. So changing any dose to IV above the 75 microgram mark would be an increment in the dose and not a decrease. That makes options C and D wrong. B is the correct answer, in my opinion, in this case. So let's move to the next question. The mean decrease in heart rate after initiating a beta blocker by the name ABY in 90 patients was 24 beats per minute with a standard error of 3.78 beats per minute. Underscore those two values. So my question to you is, what would be the 95% confidence interval for the decrease in heart rate after initiating our new beta blocker ABY? Is it 16.64 to 31.4 millimeters of mercury? Is it 20.22 to 27.78 millimeters of mercury? Is it 14.55 to 33.45, or is it 22.28 to 26.28? I'll give you 10 seconds to make your choice. From my quick arithmetic, A is the correct answer, and I'll give you 10 seconds to read the quick computation of how I got to that figure. Now, if you need more time than that, then you'll be advised to rewatch this video at a later stage. So let's move on to the next question, which reads, ATG is an 84-year-old female patient who comes to your A&E from a nursing home with shortness of breath. Now, her past medical history is COPD, diabetes mellitus, schizophrenia, hypertension. Now you do a chest x-ray upon admission and it shows you pneumonic infiltrates in the left lower lobe of the lungs and possible early pneumonia in the right lung base. Now her WBC at this stage is 15,300. She has a temperature of 102. Her heart rate is 103. And her blood pressure is 134 systolic, 65 diastolic. Now while in the nursing home, she was on albuterol and atrovent nebs. She received amlodipine for her hypertension. She received risperidone for her schizophrenia, metformin and glimepiride for her diabetes type 2, losartan for her hypertension, and because of the COPD, she was on prednisone. Now, as a steroid, it made her sugar control a bit tricky. Now, my question to you is, which of the following would be the appropriate antibiotic to treat her pneumonia at this stage? Would you opt for infusions of 750 milligrams levofloxacin infused over 90 minutes alongside 2 grams of ceftriaxone infused over half an hour? Or would you infuse 750 milligrams of levofloxacin over 1.5 hours and do an extended infusion of 4.5 grams of piperacillin tazobactam infused over 4 hours every 8 hours? Or would you infuse 4.5 grams of piperacillin tazobactam over 4 hours thrice daily and 2 grams of cefepime over half an hour? Or would you infuse levofloxacin, piperacillin tazobactam, and infuse vancomycin over an hour? I'll give you 10 seconds to make a rational therapeutic decision. In my opinion, options A and B are incorrect. Remember, there is a risk of having an MRSA infection. Now, options A and B have no MRSA coverage. Yeah, she's from a nursing home. Now, option C is incorrect because we are basically doing double pseudomonal coverage without MRSA coverage. D, in my opinion, is the correct answer because she came from a nursing home, and yeah, we need to cover both pseudomonas and MRSA, and there could be risks of multi-drug resistant microbes having caused the infection. Yeah, so she should be started empirically on 750 milligrams of levofloxacin IV infused over 1.5 hours, vancomycin over at least an hour, and to get good results, we would take advantage of the fact that piperacillin tazobactam exhibits time-dependent killing and use prolonged infections lasting 4 hours. So we would infuse the dose of 4.5 in 100 ml of normal saline over 4 hours. Now, depending on the number of IV fluids that a patient has, you could do the entire daily dose of piperacillin tazobactam in half a liter of normal saline infused continuously over 24 hours with brief breaks if the patient is ambulatory and needs to go to the toilet. You can comfortably do a 24-hour infusion because piperacillin tazobactam solutions in normal saline are stable for 24 hours at room temperature. So let's move to the next question. Let's move to our last question. Imagine you are transferring this patient to the ICU with community-acquired pneumonia, and assuming she has no penicillin allergy and no pseudomonal or pseudomonas risks, what would be your best choice of antibiotics? Would it be levofloxacin 750 milligrams IV over 90 minutes alongside 2 grams of ceftriaxone? Would it be levofloxacin alongside vancomycin? Or would it be azithromycin alongside vancomycin? Or would you infuse levofloxacin, piperacillin tazobactam, and vancomycin? I'll give you 10 seconds to make a decision. would opt for A and infuse 750 milligrams of levofloxacin over 90 minutes, basically to avoid arrhythmias. When fluoroquinolones are infused at a faster rate than that, you'd prolong the QT segment and end up with arrhythmias that would complicate treatment. Now, I would infuse that alongside ceftriaxone. A is the correct answer because according to the IDSA CAP guidelines, antibiotics that should be started include a beta-lactam and either a macrolide to cover any atypical bacteria or a fluoroquinolone for patients without penicillin allergy like this one. Now, for any patients that have a risk of pseudomonas, the empiric therapy can be piperacillin tazobactam plus either levofloxacin or ciprofloxacin. Now, that does not apply to our case. Now, B is a wrong option because it doesn't include a beta-lactam. You are basically covering MRSA and the atypical bacteria. But we know that levofloxacin in case A can also cover the atypical bacteria. So B would be wrong. C and D are wrong because piperacillin tazobactam is fairly broad. It gives anti-pseudomonal cover, which we do not require in this particular case. Now, vancomycin is inappropriate because this is a community-acquired pneumonia, and therefore the patient may not be at a risk of having MRSA pneumonia. Now, if it were a healthcare or a hospital-acquired pneumonia, then I would add vancomycin. I hope those patient cases will help sharpen your skills as you deliver pharmacotherapy to your esteemed patients. So, my esteemed viewers and listeners, if this video helped you in any way, remember to give it a thumbs up and to subscribe to my YouTube channel. I would like to reassure you that the best is yet to come. Thank you for viewing and listening, and I hope to interact with you again in part 2, part 3, part 4, part 5, and subsequent parts of this series. Thank you very much, and I appreciate your cooperation and your partnership.